introduction से live कर दे.
Now I will call Dr. Fawad Farooq. He is going to talk on the role of carvedilol in essential hypertension. Besides excellent cardiologist, he is a social media star as well.
Thank you, Javed, for the introduction. Do we have slide changer? If you can give me a slide changer as well. It's not exactly just carvedilol. I'm covering the third generation beta blockers in hypertension. Nowadays, it's very difficult to talk about beta blockers in hypertension. But at the end of presentation, you'll come to know there is still place for beta blockers in hypertension. So the concern, it's greater than widely used of hypertension and still recommended as a first line agent in a number of guidelines when you have compelling indications. And you'll come to know there are a number of compelling indications. That's why you have to use beta blocker in hypertension. But recent meta-analysis, like past 20 years, have shown or created controversies about use of beta blocker as a reason that it has been do reduce blood pressure, but they haven't been really. That's the one thing which has created a lot of controversy about the use of beta. Adverse outcomes, diabetogenic, they have some adverse effects in dyslipidemia, and that has led to people think of using other alternatives as compared to beta blocker, but it is as a first line agent. And when we say first line agent, it means that you're saying that your patient is having no other comorbids and you're selecting drug for pure hypertension. Since there's shortage of time, I'm not going through complete data, but there are multiple trials, either in comparison to placebo or in compared to other drugs, which led to this notion of beta blockers issue in not reducing stroke or having adverse name of all those trials displayed here. I'm not going into the details because of shortage of time. Meta-analysis has shown that excess risk of stroke, 16% associated with the use of beta blocker, it was other antihypertensive agents. And that has led to this kind of guidelines, A plus C, A plus C, A plus C plus D, and then at fourth stage you're founding beta blocker as an agent to be used in hypertension. That's a nice guideline. In JNC 8, again, you don't found beta blocker as a first line. In ACCHA 2017, again, no beta blocker as a first line. But the issue was in these all trials, most of the time drugs which were used were older generation beta blockers, and which doesn't have the best profile as compared to the newer generation. So can we extrapolate put it to the other? I don't know exactly. Can we take all beta blockers as a single agent under single heading? I don't know. But that is a matter of concern. And similarly, age, a very prominent confounding factor, wasn't considered in these all trials. Most trials were above 55 years of age. And hypertension hemodynamics are different in different age groups. And that we'll see in a moment how it affects it's in terms of outcome when you're using beta blocker in an old age patient as compared to a young age patient. So this all data is not enough to say across the board that every beta blocker is in same heading and can't be used. So you have to look for characteristics and profiles of individual drugs to decide which one to be used in which condition. So you just don't say that two things are same. It all depends on profile and characteristics. Blockers, when we say they affect by means of addressing beta receptors, these for junior, you have beta 1, beta 2. I'm not going into the details, just showing you the actions. If you block, actions are due to beta 2, and these yellow actions are due to beta 1 blockage. Now increased peripheral resistance, and you'll found all the adversity are there with vasoconstrictory effect, peripheral vasoconstriction, that has led to all these issue of increased stroke, adverse metabolic profile, while the beta 1 is doing nothing. All beneficial effect, force of contraction, decreased myocardial oxygen consumption. And that's why previously when we divide beta blocker, we divide them as selective and non-selective. But now when we see beta blockers, we see all other properties as well, whether they are vasodilatory or not, which is not there with beta blockers. Propranolol, atenolol, these all have peripheral vasoconstriction as their main action. So that's why causing all those problems which you're facing. And now you have vasodilatory beta blockers as well. So now you look for beta blockers, not just beta 1 or beta 2 selectivity, whether they are vasodilatory, their efficacy, metabolic profile, and side effects. And these newer generation beta blockers have shown metabolically either neutral, in some study, some benefits as well. And that's why now you're not dividing beta blocker as beta 1 selective and beta 2 selective. You're dividing them according to generation. First generation, second generation, and third generation. And third generations are one which have vasodilatory properties, nebivolol and carvedilol. And that's why when you look onto the evidence in which atenolol or other beta blockers versus other drugs, you found different outcomes. There's a stroke issue was there with atenolol and losartan, that was life study which has shown this issue of increased stroke. But in these old trials, these older generation atenolol and propranolol were used. Now you look onto the data with newer generation, it is slightly different. Stroke inconclusive, MI benefit, total mortality reduced, good results with other beta blockers. And similarly, in terms of hemodynamics, the main issue was peripheral vasoconstriction, which is now with newer generation vasodilatory beta blocker, you are reducing beta blocker, which is a very unusual effect. Similarly, hypertension in elderly and young has different characteristics altogether. Low arterial compliance in elderly and high cardiac output in young patients. So you will found a really place of beta blocker in a young tachycardic increased sympathetic activity patient, and you found benefit of those that use as well. And that's why you'll see in ESH 2018, it is recommended as an antihypertensive treatment with a 2-drug combination preferably, and beta blocker combined with any other drug when there are specific clinical indication. And I'll show in a moment the compelling indication of beta blocker really can't allow you not to use beta blocker in hypertension. I'm going to those because of shortage of time. You see heart failure, coronary arteries, tachyarrhythmias, increased toxicosis in migraine. And this increased sympathetic activity we usually don't consider in our young patients. These baseline tachycardic 90, 100 heart rate, always in an anxious state. And when you give them beta blocker, you will find a relaxed state that certainly your pressures are controlled. So you'll found you have to judge your patient and then decide which of your patient really needs beta blocker and which really doesn't. So in conclusion, I'll say this vasodilatory property in a newer generation beta blocker have made them a good choice in patient where you found a compelling indication. And out of those all compelling indication, your baseline tachycardic state, your patient, inappropriate sinus tachycardia in a hypertensive patient is a very strong compelling indication to use beta blocker. And even in moderate to severe hypertension, when you're choosing 2 or more than 2 drugs, a number of times you use one drug as a beta blocker and the other one either a combination of amlodipine, valsartan, or now even you have valsartan, amlodipine and thiazide. So whenever you're choosing 2 drugs, actually you're choosing 4 drugs and giving 2 pills. In that you have to give beta blocker as the other pill, and other drugs you have in 3 combination. So that's why I think with this journey of beta blocker, with these new generation vasodilatory beta blocker, they are not the same as were the older one, atenolol, metoprolol and propranolol. So with that, I'll conclude that considering all beta blockers same in their pharmacological profile is unjustified. And second, cautionary advice to use beta blocker as a first line agent in hypertension has run overgeneralization, leading deprivation even in the needed patient as well. Thank you for your patience listening. Haven't bothered the moderator to.
I have a question for audience that whether